now to get into proceedings. To start with, before we actually get into our session, which is on unlocking the complexities of integrated care, innovations and implementation science, I'm going to invite Dr. Nick Goodwin, who's known to many of you. He's Chair of IFIC Australia, to present some awards, and then he'll start speaking on the topic. Thank you, Nick.
Thanks, Alison. Yes, so at each conference we award prizes for the best oral papers and also the best posters, so we've got 3 prizes to award. So the prize for best poster and winning $250 is a paper in the area of palliative care. It was actually recommended for an oral presentation, and it looks at an important aspect of care at the end of life, robust methodology, transferable and scalable knowledge. Actually, from the Peach program, it goes to Josephine Chow from Southwestern Sydney Local Health District. I know she's not here, but give us a round of applause. This is around meaning making at the end of life. Do we have someone from Southwestern Sydney to take the award on Josephine's behalf? Yes. A round of applause, please. I'll stand in front of that one. All right.
Fabulous. Thank you very much.
Congratulations again. Okay, the Best Poster Award. So we have a runner-up for the best oral paper, and this really focuses in on some exciting and innovative work, particularly in how we can get professional integration and cross-disciplinary training. This goes to the paper on clinical genomics, integrated team working across the socio-technical divide, to Dr. Stephanie Best from the Australian Institute of Health Innovation. Is Stephanie in the room? Yes, please come. Congratulations.
Thank you. Lovely. Well done. Thank you.
Great.
Thank you.
And the winner of Best Paper Award, winner of $1,000. Actually, this is it's interesting because this is in an area of oral health, and that's been a major theme of this Congress. And I remember in San Sebastian, a colleague came up to me and said, "Why don't we do a special interest group in the area of oral health?" And sort of ummed and ahed about it. But actually, we created something, and then this conference has had oral health, many different oral health papers. So within that, the winner goes to Susan McKee, Dental Health Services Victoria, for her paper on oral health for better health, a value-based oral health care model in Australia. Okay, so straight into plenary. This session is very much around innovations in implementation science and how we think around our implementation of integrated care strategies. And I was reminded at the break from a colleague that maybe a couple of years ago when we held the conference, people were beginning to talk about, a lot of the concepts and ideas and strategies of integrated care. And here it's been a lot more granular in terms of thinking through how we can devise strategies of implementation. So my name's Nick Goodwin. I'm Professor and Director of the Central Coast Research Institute, which is the joint venture between the Central Coast Local Health District and the University of Newcastle. Only been post a few months, but very much the idea is, and what attracted me to come to Australia was the ability of a university to walk alongside the health service to develop approaches to research and innovation that can have a direct societal impact in the communities in which they're placed. It's a very exciting opportunity for me. And I guess throughout my career, I've been very much a kind of a black box kind of man. So many arguments with health economics around the impact of different research studies. When I know the answer, it depends, and it depends on this thing in the middle called the black box. Because within that, and particularly within integrated care, many complexities occur, and this will be the nature of the talk. But to understand the black box, I think we first have to kind of understand what integrated care means. And I think the reason for going back to this, what is integrated care, is because if you're going to examine the nature of the black box, we need to understand the reason why we're looking into that box. What are the outcomes that we're seeking to achieve? So we know from the presentations that we've heard is that integrated care is necessary, where fragmentations in care delivery mean that care has become so badly coordinated around people's needs that it leads to an adverse or suboptimal impact on care experiences and outcomes. And we heard from the care experience panel exactly that phraseology by saying that the fragmented care is actively providing poor care for us, particularly to the most vulnerable. Secondly, therefore, integrated care is a quality improvement methodology. It's there to improve care experiences and outcomes and cost effectiveness, to ensure services are better coordinated, well coordinated around people's needs. It is by definition, therefore, both people-centred as well as population-oriented. Therefore, again, as the last panel was talking, it's the people's perspective that becomes that organising principle. And I think this is important to make this distinction between integration, which is a set of processes to bring together things that were previously fragmented in order to be able to care. And therefore, if we take this as what integrated care means, it gives you a reason, it gives you an opportunity to understand the common outcome frameworks in which we're seeking to assess what's going on with it. So the integrated care hypothesis is around how do we improve system performance in terms of improving users' care experiences, their care outcomes in two ways, not just they're better able to manage their own care or having an effect on their quality of life, but also seeing reductions in the utilisation of services that are unnecessary, whether that be hospitalisations or institutionalisation in nursing homes and so forth. It's also an approach where, done effectively, we're thinking that we can create value and cost effectiveness out of integrated care. And hopefully, because integrated care is quite problematic to put in places, it requires a lot of teamwork and people coming together in different ways, maybe we can actually improve the work-life balance of care providers and professionals by making the system more interesting and perhaps less stressful as a work environment. That's the hypothesis. The evidence is perhaps a little bit more mixed. Where integrated care better coordinates care around people's needs at that personal, clinical and service level, it can certainly improve quality of care and care outcomes and care experiences. Lots of evidence for that. But uncertainty remains on the nature of the system and how we create a system at an organisational or systemic level that enables that to occur. And because we're not always successful in the way we set up the system, these new structural solutions are often seen as costly and invariably seen as not necessarily providing the results that we would want from them. So getting the design and implementation of your integrated care programs is very important, and that requires time. Liz's presentation earlier demonstrating that economic evaluations to date have found it quite difficult to find evidence in terms of the cost efficiencies of different programs, and you see it in case management, you see it in lots of different areas. This is partly because we haven't given innovations time to embed and develop. So you're really only looking at these innovations when they're at 10% of their maturity and capability. We need time to develop before we can really see the outcomes. And also research studies really don't look at integrated care in the way that we previously devised them. They look at integration, they look at organisational structures, they look at new types of alliances, they look at new types of care teams. But you're not really focusing down at a micro level where the transformational impact happens, at the interface between the care professionals and the people in which they're supporting. Valuation often fails on that. So as a result of that, as an advocate for integrated care, there's an Achilles heel here about the robust evidence overall on the economic impacts of integrated care and therefore our capability to invest in these types of new innovation. And I don't think this is a design problem. This is not the design. There are only so many different ways in which you can support care management in people's homes, and we kind of know what's required. Only certain different ways in which we're going to develop a care pathway for a person with cancer, and these have been designed in their clinical standards. So it's not really the design of the programs that's necessarily a problem. It's the fact that we have a very weak understanding of the implementation and the implementation science behind it. So when I was looking into, I was at a conference in the UK, how do we look into these complexities to find out what works. Well, when you look at program evaluations that are trying to see whether, say, the integrated demonstrator program or other forms of the healthcare home programs have been effective or not, actually they tend to have very limited ability to explain their results, so making it problematic to judge impact and costs. So to give one example from England, there was a program of work under the five-year forward view. They created a number of different new models of integrated care, and one of them was called Multispeciality Community Providers, which was really putting specialist roles in primary care settings. And over time, these new models of care weren't really making any significant difference in terms of the cost effectiveness of care. But in the third year and then in the fourth year, beginning to see a divergence in terms of their capability to reduce overall admissions within a hospital setting, with great variation between the different groups. But when you go and ask, what was it that actually is making the difference? Nobody knows, because all of the different providers are organised differently, they're structured differently, they're led differently, they're funded differently. Something's happening, which is great. We don't actually know what's going on, which makes it very difficult when we say, well, we will have one of those, because clearly it's very effective, when you have no understanding of how you're going to implement it. And then you get to the process evaluations. Well, we've looked at the program evaluation, it seems to be making an effect. Therefore, we need a process evaluation to be able to understand what's going on beneath that. How do we influence the design and delivery of our programs? However, what happens there is you end up with a range of key variables. You look at the number of different variables in implementation science and say, oh, well, it was a financial issue and the finances ran out. It was a political issue, or it was a cultural issue, or it was a relationship issue. And these are the variables. And it would have worked well if it hadn't have been for these different aspects, or it only worked well because key people and leaders were involved. That's not terribly helpful either, because it's not giving you an understanding of the methods and tools that you're going to need to be able to develop the collaborative capacity that's required and invest in workforce skills or invest in different system capabilities in order to be able to get to where you need to go. So what you get from this weakness is the need for perhaps a more intimate relationship between research and practice. How do we understand these complexities in the context of their implementation in order to be able to support quality improvements in real time? And I think this is one of the things that attracted me to come to work on the Central Coast, is how can we create a capability that enables us to translate that knowledge much faster in order to be able to support innovations and improvements. But without that, currently our ability to replicate, adopt, scale up, sustain different integrated care innovations in different contexts is lacking. Everyone says, where's the scale up? Where's the replication? And there's a reason for that. And I think the reason is in design. I think the reason is in implementation. So how can we explain things? Here's a good example, the example of multi-speciality partnerships. This is a really good example from Cumbria, beautiful part of the world, rural as you can get in the English context, up in the northwest. This is the Lake District, but lots of small remote communities. And in one of those communities in Milham, they created an alliance because they needed to be able to look around all of their community assets to be able to provide services to local people, because the GPs had handed in the keys. Once the GPs had left the district, the community hospital had to close. The community had to think of all sorts of different ways which we can grow a community health response for the people in that community. So they used an assets-based approach. They developed a community care organisation. The community, in a sense, began to own and create the different kind of support mechanisms for that community, and they were able to therefore go out and recruit some new GPs. And in response, the care teams or the GP behind this was able to create other forms of alliances. But it was this community-based approach. And this approach was replicated across 20 community-based alliances 4 years later, across 750,000 people across that community. And the community turned around in 4 or 5 years from probably being at the bottom of the pile in public health outcomes to somewhere in the middle, and went from shipping money year on year and being in substantial deficit to making an 8 to 10% year-on-year savings in terms of their operational budget. It's quite a remarkable turnaround. And this is the equation that the key GP puts together, integrated care equation, if you like. We need integrated health and social care teams, but these are real teams, and they support real care pathways. We have activated individuals, carers and families. We have communities mobilised at scale, and we have change drivers in the system, good leadership, system culture, norms and values, and therefore you get a population health and wellbeing system. I like equations, but this causes a problem for me because on each of those steps, a miracle has to occur. Because we don't know, how do we make a real team? What does that care pathway look like in the context of my community? How do we activate individuals when they're not necessarily engaging with us to a great deal of extent? And the community isn't empowered enough or supported to be able to come together to give us their advice or participate in care. Where does the leadership come from? How do I create culture? None of these questions are answered in that diagram or in that equation. And sometimes miracles do occur, in which case you're blessed, but usually we have to work at it. So someone said before, we need to invest in these kind of management and relationships. So in thinking about the diffusion of innovations, there was a key paper by Trish Greenhow and colleagues from around 2004 doing a systematic review of complex service innovations, really coming to the conclusion that we don't have any robust understanding about how these can be implemented and sustained across different contexts and settings. I hope the same is true today. So this is a three-part problem. This is Sherlock Holmes. It will take him 50 minutes. You normally can get to the conclusion straight away, but this is his three-part problem. Well, it's taken me 20 years and I still don't have the answer. But Sherlock Holmes could do it in 50 minutes. So there's a need to unpick how outcomes result from that intricate interplay between multi-component interventions in different contexts and settings. So therefore we need the kind of methodologies, research methodologies that can begin to help. I'm not going to go into those because I know the next presentation goes into much more depth. But what I will say, so what is integrated care again? Integrated care is not an intervention. Integrated care is a combination of two sets of implementation activities. It's around the integration of things. How do we bring together things that were formerly fragmented or misaligned into some sort of cohesive approach? And secondly, it's about care, the process of caring for people and populations. It's not a defined intervention as much as you'd like it to be. It represents a suite of values, principles, methods and tools that seek to come together in different ways to overcome these care fragmentations and improve quality. It's an activity. It's about implementation. It's about how we do things differently. And that means that research and evaluation have to recognize that there's no discernible difference between the intended intervention, say the design of a case management program, and the implementation of that intervention in terms of how it is taken forward. The two things have to be seen as one if you want to get to an understanding of effectiveness. And this helps explain a lot of things. It helps explain why case management programs probably have the most conflicting evidence that you can possibly imagine between high effectiveness and low effectiveness. It explains why you might remember going to Boston in Massachusetts and they had an aggressive case management program for people with COPD and other chronic illnesses, and it had a huge and beneficial effect in terms of cost effectiveness for the pilot group in which it was implemented. And then they took it next door to the next context and it had the completely opposite effect. It actually increased hospital admissions. It was more costly to administer. The people in that community were less engaged as a result of it. And the reason is you're trying to implement something in a context that was not suitable for it. It helps to explain all of these different types of things. So, if we're seeking to promote a translational research agenda, implementation science needs to move away from generalized explanations of variance to examine and test the implementation processes themselves. That's my hypothesis for this afternoon. The nice picture on the right is Avoca Beach. That's where I'm living. So as long as the bushfires stay away, it might be another reason why I came to Australia. What about a different evaluation framework? Second part of the presentation. There's a need for new assessment frameworks, not just to support integrated care, but other forms of complex service innovation because of this lack of evidence supporting how to design, pilot, implement, and assess integrated care. Most of the existing diagnostic frameworks that we have at the moment set out the key building blocks of an integrated care system, but they're unable to articulate or give you the understanding of those dynamics or those tools that support the interrelationship between the factors. Some understanding of the complexity, but lack of understanding of how you untangle that complexity to support managerial decision-making and effective implementation. Very few tools out there to support it. And the problem with that is that this is difficult because system failures in integrated care are very common. The mortality rate amongst integrated care schemes is very high for all sorts of different reasons, as listed on the left. Political changes, the finance and incentives, grant money for a couple of years and then it disappears. Whole range of different things, professional tribalism, social norms and values that are not shared, and so on. So they require constant effort to nurture and build. Culture and values are important. But there's often a lack of, this is the thing for me, is that even when you go to the British Medical Journal, we're not going to publish any more of those nasty qualitative evaluations that just tell us how things operate, because we've got to focus on the high-level evidence of randomized control trials. Randomized control trials and complex service innovations really don't mix, and they particularly don't mix when you're trying to get real-time evidence to support integrated care in practice. So we've got to overcome this thinking, which is born out of the medical thinking, start to think around how do we bring the evidence to the forefront that enables us to assess the ability of care systems to adopt things successfully. This is really important. And assessment frameworks can help guide research and evaluation, of course. Nellie Olker is in the room somewhere, I think. This was from her work with Esther Suter and colleagues, having done a systematic review of indicators and measures and tools for health system integration and knowledge synthesis, and again saying, findings highlight a continued gap in tools to measure foundational components that support integrated care. Continued progress depends on our ability to evaluate successful strategies across different levels and contexts. So again, more evidence that implementation science is weak. And yet there are a lot of different frameworks emerging. I've presented on the framework on the right many times, the rainbow model of integrated care and how we need capabilities at different levels to make the system operate. I won't go into those. But you see on the left-hand side some different perspectives of how we understand the implementation of integrated care systems to work. And some of these models have actually been tested out and demonstrate that when you put in the components of these models, they actually support better care outcomes more cost effectively. From chronic care models and a disease perspective, you've got systems perspectives, project perspectives, governance perspectives, lots of different perspectives, and there are lots of different frameworks. But note three things. Most of these frameworks forget this is about people and populations, so the people-centered care and the ability to activate and engage and empower local communities and people is often missing within the frameworks. Secondly, they forget about the workforce. Most of these frameworks forget that workforce capabilities need to be built, how we work together in teams needs to be generated, and so on. And relatively little understanding of how the building blocks come together in an operational system. One of the tools that I was involved in from a project called Project Integrate, a lot of thinking went into that title, came together to work through all of this evidence, collected it together into what we call now the Integrated Care Initiative tool. My support from the Centre for Rural and Mental Health, who are here, and colleagues, and we tested this out actually on the Central Coast. And it has a number of different domains, and the idea around this is that you're able to look at the maturity or the capacity of your system together to be able to look at different elements of your integrated care project and to see whether you're strong or weak in these different areas. And this gives you a baseline to be able to work through where do we need to have investments in the future. But interestingly, work that my colleague in the Netherlands has done in this area has been to look at the interplay of these different factors versus the outcomes that one can achieve within a health system, particularly outcomes that matter to people. And what you find in that is that across these 7 domains, the one area that will demonstrate better care outcomes for people and support higher scores across the whole of the system naturally is related to the extent to which we are effectively coordinating services with and around consumers. So how professionals are working together, but that element is affected not by governance or finance or these other systemic factors or how we organize things. Those behaviors are driven by how data and information is effectively communicated across the system. That is driving the behaviors to support care coordination. So that's a really important tool because it goes back to all of that knowledge that the transformational effect of integrated care is felt at that interface between care professionals and people at a local level. But where do we place our evaluations? Somewhat higher. So we need to get deeper into our understanding of implementation to do it. We also need to think through our theory of change. I've lost track of the number of program evaluations that I've been involved in, where actually there was no theory of change whatsoever. So you're trying to look at an outcome, but the outcome was never going to happen because the intervention was never designed to achieve that outcome. So we need to start thinking around some program logic and plan a program evaluation so that we begin to understand better the components that we're putting in place for integration that will actually lead or have a logic to lead to outcomes over different time periods. So I think that's another thing that's important. And then maybe the final thing to say is, if we start to put all of this together, what does that mean in terms of thinking through? Do we have an idea of how we can put together an implementation model for integrated care? And this is something that I put together originally for the World Health Organization and then for a European Union project called Care Well. And really I won't go through it, but on the left-hand side, all of these different change management steps that one would need to do when you're building a project, from doing a needs assessment and a situation analysis that will lead you to an understanding of the problem, through to building up a value case, looking through your intervention, what's the value case, what's the logic in order to be able to get the outcome that you're looking for, and from that to build a vision and mission strategic plan, which you then roll out and implement, tests of change, monitor and evaluate, and you go through that cycle. It's a quality improvement cycle, it's a commissioning cycle, it's a Kotter's theory of change cycle, it's all sorts of different things. It's a change management steps. But importantly, on the right-hand side, every single one of those steps, you've got an opportunity to build in the necessary relationships that will be required to make that integrated care program more effective at the end point. So from building a guiding coalition in the early phases to building support for change from all of those stakeholders that are going to be involved in this enterprise, and to develop that collaborative capacity. So when this hits the front line, the GPs or the community health workers actually have the competence and capabilities and the skills to be able to take it forward. I won't mention that, I've run out of time. So just some concluding remarks. Does Australia have a narrative for integrated care? So some final flow-away remarks. And I think there's an issue here that I don't think there's a compelling enough narrative for integrated care. I think we heard it yesterday from the Secretary. That was a really good speech. But I don't think necessarily overall across Australia we have that. There are a number of different priorities that I think are necessary to take integrated care forward. And I won't go through them all because you'll be able to read them afterwards. But we'll finish with, we need to evaluate the impact. And if we're going to evaluate the impact of integrated care, we should focus on value, not volume. We need to avoid trials mentality. We need to share that innovation and learning in a meaningful way and focus on implementation science and quality improvement to get the guidance that we require to implement things more effectively and consistently in practice. With 3 seconds left. Thank you.